And so with each of the disorders, there's going to be some effect probably on different functions, different brain or mental functions, such as attention and memory and focus and beliefs and motivation and behavior. So any approach has to take into account that all of these functions, or any or many or all of them, may be affected within a particular diagnostic framework. Now, the generic cognitive model is kind of a template. And given this template, one can look for specific features across any of the disorders and then look at what's actually specific for a given disorder. And many times when I've done a workshop, people would say, well, do I have to learn something new for each of the disorders? Or is there some easier way of going about it? And my answer to that is that there is this generic cognitive model which runs across all of the disorders. But there's one difference for each of the disorders which can account for the disorder, and that is the meanings that the patients attribute to their experiences. And the meanings have to do with the beliefs that the people have. So the disorders are similar in many ways, but they're differentiated by the specific beliefs that the people have. However, as with anything else, the cognitive therapy has to be adapted to the particular patient problems. So when a patient is in severe depression, you can't necessarily start with a cognitive restructuring, such as what are the alternative explanations, does it logically follow, and so on. What they have to do is they have to get activated. They're in a state of torpor, basically. And by getting them activated, then you can help to neutralize their negative beliefs about themselves, such as, I'm useless, worthless, I'm never going to get better, and things are only going to get worse, and so on. Called behavioral activation. And that consists of giving the patient a whole series of activities and have them rate the activities. And so many of them will have the attitude, well, okay, so it was very hard for me to make a phone call, but I followed your advice and I made a phone call. But what does that matter? No, anybody can make a phone call. And then you say, no, but that's a mastery experience, because for you, making a phone call is very difficult. And so what you have is a good mastery experience. So you have to rate this as a mastery experience. And then the other thing is we would have them note down anything that they did that was pleasurable. Ordinarily, if you ask a highly depressed patient if they had any pleasurable experiences during the week, they will say no. But as it happens, if they go hour by hour, they do have pleasurable experiences, but they don't remember them. And so what we try to do is to get this really indented into their minds, that they are having pleasurable experiences and that life is not as unpleasant as it seems. And so I borrowed some of his thoughts, some of Ellis's techniques, and I would have people now start to examine their thinking, not challenge them, which was Ellis's term, but to start to explore, investigate, evaluate their automatic thoughts. And we would do this in a variety of ways. One is if a person had a negative thought, such as, my wife doesn't love me because she ran off without saying goodbye. So we'd say, first of all, is this the only time she's done this, or does she do this a lot? Second, that's selective abstraction. Are you making some general statement? This is overgeneralization, and so on. And then we say, now, is there some alternative explanation? Or does it logically follow that the reason she went off is because she didn't care for you? A whole variety of techniques. The activating stimulus may be something like any kind of somatic sensation or some kind of psychological sensation can be the trigger. And so it could be something like pain in the chest, or it can be a feeling of faintness, or a feeling of depersonalization, anything that seems to be a little bit strange or worrisome to the patient, and it will vary from person to person. Now, what happens next is that a particular belief gets activated, and a belief may very well be something such as faintness could be a sign of having a stroke, or it could be a sign of having a heart attack. And so the patient then gets the belief, oh, I could be having a heart attack, or I could be having a stroke, or I could be dying from this. And the patients actually do feel as though they are dying, as though they are actually having a heart attack. So the imagination starts to play a role in this. And a lot of these patients actually have images of these things happening to them. Had patients who even would have the image of themselves having the heart attack and ending up in a coffin, and they quickly get that image. And so you get the stimulus, you get your belief, which gives the meaning, and the meaning then can come out in an imaginal, pictorial form and just in a verbal form. And then the important thing is the focus. So the attention that gets focused on the stimulus, and the more it gets focused on the stimulus, the worse it gets. The more they think of the faint, the worse they feel. And then the consequence of that is that they then will run to the emergency room, or they'll call somebody and get reassurance that this isn't happening. Now, through something that the learning theorists call reinforcement, positive reinforcement, as long as the patients go for reassurance, it tends to keep the cycle going. And so the consequence itself, then, the reinforcement or the reassurance that they get, tends to prevent them from working through the reality. Now, so the therapy then follows very logically from this little paradigm. So let's just say we get the stimulus of the activation, might be a pain in the chest, say. And of course, you do want to get medical clearance if you're actually working with such a patient. But most of the time, the pain in the chest may be simply just in the rib cage, and you can reproduce this little pain in the chest. As people get these little pains lots of times, but they're not aware of it unless they're hypersensitive, hypervigilant. So you can reproduce the pain sometimes by just pressing on the chest. And so you give the patients a different explanation for what's going on. The people who feel faint may have something that's called postural hypotension, which means their blood pressure drops. And you can get them to stop the faint feeling by squeezing a rubber ball, say. And it isn't just getting it's not just a question of getting this thing to stop. It's trying to disconfirm this belief that they have. So you disconfirm the belief through cognitive restructuring. Now, another thing is, I say they focus on the symptom. So another technique to use is to teach them to focus on something. So a fairly significant proportion of the population are disabled, or certainly are very dysphoric because of chronic back pain. So they start to feel a pain in the back, and then they get the thought, the belief then is the pain in the back, this is terrible, it's uncontrollable, I'm not going to be able to do anything. They then feel sad, and then they withdraw. And in these cases, you often have to work with the total withdrawal that they have and get them not to withdraw, because they still can have a capacity to do things. So that can then neutralize the idea that this is a disability. And actually, we've done some research on this, so that's why I'm talking about that, they often become very self-critical. They think their other belief is, I'm just an anomaly, and I'm different from everybody else. I'm not going to be able to do things for my family, and they become very self-critical. So you then can deal with the depressive components.